Welcome everybody to podcast time. I have with me we have Jeremiah Johnson, and then we have Dr. Aaron Roberts.
It's not even funny.
Dr. Aaron Roberts graduated doctor school with me. And he's a real nurse practitioner now, doing nurse practitioner things, nurse practitionering people. Just super awesome. We're talking today about psychosis and psychotic disorders, because Aaron has some cool experience in the ER. But I think I wanted to talk about Aaron first, and maybe talk a little bit about your path in nursing and kind of how you got to where you are today.
Okay.
Is that cool?
That sounds fine to me.
Okay.
I kind of did the long route. So for those that are starting off in the community college setting, that's where I got my foothold in nursing. And so back in '94 is when I entered nursing. Well, not nursing school, but I started my ADN prereqs and then finished up in '99. And then after that, I worked for about 10 years on several different psychiatric settings throughout California. And then after becoming exhausted with the rat race down there for 5 years, I took off and came up here to North Idaho, Eastern Washington. So I've worked in both inpatient and outpatient programs. I graduated with my bachelor's at Lewis Clark State College in Idaho, and then transferred over to the WSU DNP program. So
With me.
I've got like a lot of years.
10 years of school?
More than 10, I think it's like 14.
Oh, yeah.
15 total.
That's the best way to do it.
I did a lot of them part-time.
Yeah.
So.
You're able to work, once you get your RN, you're essentially able
Right.
to work alongside, you do everything.
I always have.
Yeah.
And that's been my bread and butter. I've
That's
always
how
worked
it's been possible.
as an acute care nurse.
Yeah.
And it's been able to not necessarily pay all my bills, but
Yeah.
I was able to work part-time and complete grad school.
Yeah.
And be a parent and at least try to.
And a grandparent.
Yeah, and a grandparent. So that was all a fun experience. So.
What got you into psych? Like going back to '94, why did you choose a psychiatric facility, or did you?
Interestingly enough, they were experiencing real shortages in community entry-level nurses at the county level, and in California they do a lot of their healthcare as regional and county settings, and so each county has a designated indigent services hospital, which is the one that can't refuse people for ability to pay, much like the Providence system is based up here. And other private hospitals can turn you away if you don't have ability to pay. And so we were the dumping grounds for every problem case. Yeah. Everybody that the police couldn't dump into a drunk tank somewhere or somewhere else. Couldn't go to the jail, so they brought them to the Psych ED, and we processed them from there. Usually about half of them got sobered up and turned loose the next day. Yeah. But that was the whole backlog, and it was a tough process to overcome.
That was a rough place to work, wasn't it?
Yeah. It had quite the severity difference in with like violence and agitation. It was quite obscene, the amount of violence that was down there, and that was probably the number one causative factor of me leaving.
I can't get hurt here.
Yeah. Well, I was getting hurt, and it was like I can't keep getting hurt.
Yeah.
And then I had a supervisor that experienced a traumatic injury, and after that, the writing was it was clear that my time was limited, being that I was a male nurse, and my size, it seemed to be correlated me with aggressive patients.
They expected you to be the first one to interact and deal with these people.
Yeah, and when you're working next to other nurses that are getting paid equal amount, and there's no gender difference, there's no difference in size, and then you look over and you see a 5 foot tall Filipina nurse, because it's like half of them were registry nurses, and so it was really you had to make do with what you did, you know, and so you ended up getting the first aggressive stance was that the nurses that were more of a force.
Yeah, for sure.
Se.
And back in the 90s probably, or even, still currently, but that was sort of the approach. Probably.
It was.
Force with force.
I started there in 98 they were hiring as student interns. That's how I was introduced into psychiatric nursing, is were experiencing such a shortage that the county had decided to actually pay students to
Oh,
come
wow.
learn what psych nursing was like.
To get the shit kicked out of them too.
Pretty much. Yep. And then they would just adopt, and they would really just coerce you to stay, and it really became part of the trauma cycle. It was like the battered wife syndrome. You really felt like, oh man.
The first podcast
like
we talked
gladiator
about,
school.
we talked about grooming. So they're essentially grooming, like,
They did.
this is what you deserve.
Pretty
You
much.
deserve this level of.
Yeah. And so
You're
people say, well, how, it was like an easy transition, and I was like, well, you see, I was getting paid $10 an hour.
Yeah.
And the highest job I had ever scored before nursing school was about $7.50 an hour.
Yeah.
When I was a nurse's aide at a nursing home for a couple years. And so when they offered me $10 an hour to do classroom lecture
You're like,
for
sure.
6 weeks, and I was like, oh, perfect, I'm signing up. I didn't even care. I could have been in an obstetrics unit. It didn't matter to me. It was like, they're going to pay me money to sit around and like do my homework. Perfect.
Yeah.
And so that's really how they taught me to do it. But
yeah.
I wasn't heading to any L&D unit anyway. I knew I wasn't the typical nursing student doing something in peds or something in L&D that's inspired by an event when I was younger, and nothing like that. So I just sort of I knew I was looking for something outside the box, and then they offered me some money, and I fell for that trap. And then, like, as soon as I got my nursing license, they offered me a full-time job. And so then it was like, well, I don't even have to interview. They just pay me, and then up the wage. And even though it wasn't a great wage for that moment in time, when you weren't used to making any kind of substantial income, it was a nice change. But it came with quite the risk, and that was the violence. And just you couldn't maintain full-time work there and not have issues with disability in the long run.
Oh yeah. It's sort of an inevitability. So what got you going to the advanced degree? So why did you want to become a nurse practitioner?
The advanced degree was, in a sense, I wanted to gain some independence with my nursing career. I'd always loved nursing in itself, and it's always been consistent, and it's always been there, and it's always been marketable and competitive. And so I've never wanted to get out of the field of nursing, and this was where I could excel in, say, like, I could make my own schedule. And then have
you did today.
Right, like I've done today. But I didn't make my own schedule with all my scheduling people, but I'm learning. And so I started a new job just
Monday.
Yeah, it's Monday, and so I'm having to. I don't have a real schedule, and so I'm kind of balancing it. So
which is the dream, man.
Well, it kind of is, and so it's all new.
And also, I think you talked to me before about, when you psych is, you learn so much with psych as you're doing it, and so you do psych for a couple of years, you do become an expert in psych. You become, maybe you don't know all the words, memorized, but you know how to recognize disorders really, really well because you've seen them so often, and you notice subtle differences and sort of this abstract, disorders that are sometimes hard to identify. You become very tuned to identifying them. So you find yourself making these clinical decisions and then passing it on to the providers and saying, this is what we should do, and them doing it, and then realizing, oh, then I might as well just do it. And so you might as well go on and become an advanced practice nurse because you have those skills anyways.
I was lucky to have some really good models. And a psychiatrist that I had worked for in Coeur d'Alene that let me do a lot of nursing per se, and a lot of help and input with the decision-making process during his medication management meetings. In order for him to, he was kind of a pill mill type psychiatrist with the 15-minute time slots, and they were all Medicaid patients, and so that's the only way we could really keep the clinic open. To afford his service, we had to keep 4 patients an hour coming in. And the only way we could really successfully manage 4 patients an hour was to hire a full-time nurse to do all the paperwork, to do all the prior authorizations, to make sure your med refills are managed. Because in 15 minutes, this psychiatrist did no paperwork. He just did his assessments and recommendations. And so that's how we did that for about 4 years.
Which that is an excellent
community health. It worked successfully, and that's where I had learned my admiration for the thought disorders. My psychiatrist, the supervising psychiatrist, had a true bleeding heart, for schizophrenia, and those chronic conditions that are interrelated with it, and the rehabilitory process involved with at least maintaining social interactions and community involvement, which really helps prognoses. And that's the kind of thing that you learn in those settings, that you can see the whole picture. And now it seems, I'm hoping that benefits me in my clinical assessments, where I can kind of step back without becoming too horribly biased or too horribly involved in one shape or form, and make the best clinical decision process and within the nursing scope. And that's where I really appreciate how the state has made advanced practice nurses completely independent.
Yeah,
and
for
so
sure.
I didn't, when I was interviewing, I didn't have to deal with supervisory requirements, and other MPs in other states are still struggling with achieving that, and being out of compliance and not being able to be practicing within their full scope, which is fairly, it seems silly.
Well, what happens is they end up just paying a physician to sign off on things.
Yeah, that's really the
end
result.
Either you get a physician who wants to help you and supervise and actually gives you really good guidance, or just wants the check to sign the paper.
Yeah.
And so I guess the intentions could have been good, but for the most part, no one really has the time for that.
It doesn't benefit.
And you just had to cut somebody a percentage.
Patient.
Yeah.
I don't see how it's they're saying it's a safety issue, or there's some kind of supervision that needs to be required for a nurse, and it doesn't.
Sure doesn't.
I don't think it adds up.
Nope, I agree. All right, so when I texted you and said, what do you want to do, you said methamphetamine induced psychosis.
Yeah.
Was your interest, and I think that's going to be very interesting. And then, but since all of our students are going to get tested on just all psychotic disorders, we could just go over them too. Mm-hmm. So I have some things about methamphetamine that I think will be interesting, and then I'll talk to you guys, and Jeremiah, jump in with your experiences with methamphetamine. Hopefully not personal experiences.
Yeah, I was going to do the whole I have no personal knowledge of those type of substances.
I have no conflicts of interest to present about my previous and past use of methamphetamines.
I am no Dr. Hunter Thompson. I did not have to live by experience. I'm not the Gonzo style psychiatric nurse practitioner.
So, my students watched a video about monoamines, so they should all know what they are. But monoamines are dopamine, serotonin, and norepinephrine. So methamphetamine blocks the reuptake inhibitor, kind of like SSRIs and SNRIs and tricyclics do, but to a higher extent, actually like cocaine does.
Right, more like cocaine.
Probably more like cocaine.
Like the SSRIs.
Right, and it is probably focused on more of the stimulating hormone, like monoamines like dopamine or norepinephrine versus serotonin.
But it's fascinating how they can all be related.
They can all be
type of receptors, and you could be related from an antidepressant to an amphetamine.
Yeah, how they're sort of the mode of action is connected a little bit, but they also force the monoamines to release from the presynaptic neuron, which in turn damages the presynaptic neuron, which in long term destroys brain tissue.
Right. I think it's that horrible flooding effect, and then it really exhausts all the receptors
all
in
the
the synapses, and they really become blown out.
Which is why you'll see people who come in with methamphetamine-induced psychosis who will be on the most intense antipsychotic therapy you'll see with no response for 2 or 3 weeks.
Especially if it's
there's no neurotransmitters.
Intoxication.
Yeah,
you really become you become the salmon swimming upstream. You're trying to overcome this agent that's stronger than the ones we have.
Sure,
At least the ones that we have that are used safely and predictably.
Right.
I mean, we could be K-darting people right and left, but those are anesthetics, and those require a lot more monitoring, and they're much more risky to do. And when they get into those type of anesthetics, some of those have dissociative effects, and I think there is a general consensus that everybody's afraid of what dissociative effects do to you
effects of these.
In the long term.
And K-dart, what's a K-dart?
Ketamine. I'm sorry, I didn't know. I thought you spoke.
No, these.
I thought you guys spoke,
I want everyone to know.
Like
K-dart.
Street.
This is.
I learned that. I learned that in the hood.
The hood. You heard the K-dart in the hood. Ketamine.
Well, I learned that in the surgical department.
Oh, okay.
of the hospital, but I'm sure the person that taught me was and like the K-hole. That was like where you end up after you take the K-dart. That's where you end up, was the K-hole.
K-hole. Oh, okay.
It's kind of this blank. It's where, and it looks like a K-hole when you see somebody that's had ketamine. You're like, oh man, I don't know how that's fun.
Yeah. Well,
it doesn't seem to go away, so that's scary.
And so, in methamphetamine psychosis, you'll see higher levels of agitation and confusion compared to like primary psychosis. Will have residual symptoms, and then they will also withdraw from the drug, which will cause depressed mood, anxiety, anhedonia, and lethargy.
And that higher level of agitation, I think, just deserves some discussion, just to explain that.
For sure.
I don't know how much experience your students are coming from out in the world, in to know what perspective is agitation. Agitation can be, there's so many different scales involved in measuring agitation. It's hard to
agitation
really
is a normal human behavior.
It can be.
Yeah, and so it's an exaggerated.
I think that's when it becomes really problematic, is that exaggeration.
Yeah.
And then you once you lose the ability to self-soothe
Yeah.
or self-control,
For sure.
then I think that's when people have to make decisions for you. And
Or-
I think that's where they become like the locked units at the hospital and stuff like that.
Or even when you take that from them. So when you go
Correct.
to a locked hospital, your coping mechanism is methamphetamine or whatever, or having sex or doing a lot of things. But if you're going to the ER, you're going to be sitting in a small room, not getting methamphetamine.
Right.
And so not only can you not have methamphetamine, you can't have any of the other coping skills, maybe, other than sometimes you can color. Right.
But the initial agitation is really in their bodies. It's really psychomotor.
Yeah,
That's the best
for sure.
way I can describe it. Is that inability to sit still.
Yeah.
And then that they're so overstimulated with the flooding of the synapses. And I guess that's part of the lure to use this drug, because I can't figure out what else is making this so fun for people to sign up to use, because it doesn't seem to be a lot of benefit.
Yeah, I don't see the benefit either, but I think people tend to like it.
And that's the strange part. I think it's more of a affordability type of issue.
Okay.
I've heard from people that I've talked to that have been in the substance abuse world that if they could afford to use cocaine, they would prefer it because it's a cleaner agent compared to the methamphetamine.
It's a more controllable agent.
Yeah, it seems more predictable and less of
Yeah.
a side effects like the psychosis and related type of illnesses that they're having to deal with afterwards. So that's always an interesting tidbit, is that they don't like to use it, but they don't really have a whole lot of choice when it comes to the addictive process. Once they get involved, they're goners. They're kind of stuck.
You're kind of stuck.
Whether you look at it as a disease or a choice, there's a whole lot of different fundamental aspects of drug addiction and any addiction per se. I think I just read in Silly News that video game addiction was now going to get put in to the DSM on the next update.
I think online is already in there, but
I think online's already there.
But now they're even going to do just regular video games.
Yeah, it's video game.
Is Angry Birds going to be on that?
Yes.
Because
I mean, I thought that was the thing, like, in 2008.
Yeah.
That was like cool to do, but I don't know. It's like you get busy and you just have to realize that the Angry Birds are just going to keep chirping. That little piggy thing is just gonna, I get so frustrated. It's like I just paid $1,000 for this iPhone and now I just threw it at the wall. So I learned the budgeting mistake.
Yeah.
Like nah. I don't need these.
That's the point. That's why
I have very little frustration tolerance for apps.
And that's just with a little bit of dopamine. But if you imagine a huge amount of dopamine.
No, that's why at a young age in my adolescence I just thought, you know what, one thing I'm never going to do is methamphetamine. Just decided that's probably not
Everyone
good.
should decide that. That should be everyone's decision.
Everybody I looked at that was using methamphetamines was not having a really good time with it. And so I realized quickly that wasn't something that anybody needs to experiment with.
When I've interacted with people with at least drug, and I think methamphetamine is the most. I mean, there's a lot of them. There's the spice, and there's the bath salts. And
I guess you could kind of call the umbrella stimulants.
Stimulants, yeah. And and a lot of these synthetic drugs that we have no idea what's doing to their brains. They come in and we don't. I remember one time we had a patient who was just so sick that he would crawl around trying to take patients' shoes away. He was throwing up on people, and so we put him. I mean, we secluded him, right? Essentially, not like isolation, but he essentially had his room that he could be in because it's such a milieu focus that there's no way he could be out of his room.
Couldn't be appropriate otherwise.
And he would get hurt by people, but they stay sick for such a long time. trying to think of other. One person, he would scream, "Fuck you!" but like repeatedly,
It just
all night long.
the cry of the wild man.
Yeah, and he would just that, and it would keep people awake, and people would be pissed, and we literally had to keep them away from getting the shit kicked out
That's
of
the
them.
one issue that I wish that administrators at hospitals and
Yeah.
treatment facilities would ever address is sound.
Yeah.
There's never a sound
that
dead
would've-
room. And I
That would
wish
have
they
done it for him. He would have
Yeah.
been fine.
I wish they
We
would
were
have
stuck with that guy.
that sensory deprivation
Yeah.
style room where you could remove noise
Yeah.
or keep noise from exiting
Yeah.
said room because
Just
it's
amps
so
people up.
it could be traumatic for
Yeah.
the others.
It is traumatic.
And I hate to bang a drum on the trauma issues, but it seems like a lot lately has been related to
Oh, yeah.
trauma and poorly managed trauma behaviors, and so that's sort of a soft spot for me as well.
And then I had one patient who he was just so randomly violent that we kept him in seclusion, but I could see him on a television screen and I could interact with him. And that was the thing. It's not isolation.
No.
You interact with him as much as you can.
You had
And
video and audio.
Yeah, video and audio. And I would print him out Lion King lyrics.
Oh, fun.
And he would walk around singing to me the Lion King. And he loved me. I had such good rapport with this guy.
See?
Because I would because he would sing to me and I would give him these lyrics and I'd give him whatever he wanted to print out. I printed him out like a picture of like a wolf or something and he drew me as a werewolf.
Yeah.
But that was when he was starting to get a little bit better, but they're all different. It's such an unusual presentation
Yeah.
that are not consistent with any of the other psychotic disorders. It's just very
And they can
unusual.
be really detrimental. I mean, it can result in encephalopathy.
Yeah.
And some of that stuff
Long term, yeah.
can be not resolving. It can
Yeah,
be
it does not
permanent.
resolve. Permanent, yeah.
And I've seen a few that just have kind of a meth brain
Yeah.
look on their face where it's just very, for lack of better words, it's a very zombie-like
Yeah.
state when they get to that encephalopathic level. And I struggle saying that word over and over. It's too many vowels.
Encephalopathy.
Yeah. And so I always end up getting tongue twisted on it, but and it results in that delirium. And then
Yeah.
once and you start doing assessments from a psychiatric assessment perspective, it's like you really have to have somebody that's coherent
Yeah.
to get
Right.
a good picture of
All
what's
the symptoms are-
happening.
yeah.
And so if your patient is very incoherent, and a lot of times methamphetamines, it causes it, and so it really slows the process down. In the emergency room, they say the average stay is like 6 to 7 hours, but on drug involved patients, that automatically bumps to 10 to 12 hours.
Wow, just immediately increased
Because of the
complication.
time it takes to sober.
Yeah.
Because meth does not process quickly. It's
Yeah.
a dirty drug, and so it stays in there while your body's chewing it up. And other drugs are much quicker. Like the crack cocaine, the high and crash is all within a
Couple hours.
Couple hours.
Yeah.
And that's really what feeds the addictive and dependence costs of crack.
And methamphetamine could be 20 hours for.
It could be up to 20
Yeah,
hours.
yeah,
I
it's
think
insane
the
amount of time.
average, if you ask people that are using, the average is about 8 hours, and
Yeah.
that seems like 8 hours is too long.
Yeah.
I would say 1 hour would be not fun. I don't understand that, and that's really what fuels that is addiction a disease versus a choice. Because if you saw the way that these people would come into the emergency room and how they leave when you're done with them, and it's night and day.
Does it-
For the most part,
Oh,
they
I
really
see.
do recover, and so
Yeah.
it's obscene why someone would choose to continue using
Right.
that drug once they've established what that drug is doing to their brain, especially if they have a pre-existing mental condition.
Yeah, for sure. What do you think?
It reminds me of that one gentleman we had at Eastern who was the nicest kid.
Yeah.
The nicest kid, and was very soft-spoken and very just polite and pleasant. But when he came in on meth, he was one that we ended up keeping in a secluded in that room that kind of kept him away from everybody else. Because he was tearing up mattresses, he was swearing, he was yelling at people, doing obscene things to himself.
Sometimes like
and-
racially charged.
Oh,
language.
Oh yeah, it could
the
Yeah,
nicest
so-
guy, and then he's swearing.
And so he would target people with different ethnicities who look intimidating that may have violent histories themselves. And you're like, you can't call that guy that.
No.
You can't call that guy
No,
that
it's
word.
embarrassing.
That's the
And
worst thing you can call that guy.
It's
Yeah.
really appalling.
Yeah.
And then I frequently worry about patient-to-patient violence.
Yeah.
There's that
Yeah.
lateral
Yeah,
violence
exactly, yeah.
that can occur because
That's a big
I
deal.
I have more of an impulse control. I'm held to a higher expectation as a professional nurse
Sure.
that I can't lash out
Yeah, for sure.
when I'm called derogatory or ethnic slur or anything like that.
but when they're flying at other ethnicities,
Yeah.
and at this point in time, politically
Yeah.
and socially, I think those type of words just, there's no use. There's really zero use for them, and so
But even
that's a struggle. When
Yeah.
I struggle to not respond.
Triggered. Yeah.
Yeah,
So.
I really do become triggered when
But these
that
people aren't
part's
using
flying.
them. They would never use that in normal language.
Right.
For the most part,
they're
they
using.
would.
They're not. They're sick, and they're just randomly saying it, and it comes probably from I don't know what it comes from, but something, some lower downstairs brain sort of phenomenon where maybe they're trying to oppose.
It's like midbrain stuff, right?
Yeah.
Isn't that where all the primitive action?
Yeah, primitive
happens,
action.
Right? It's like all dinosaur brain.
And so, like it's kind of like you
don't have awareness of it.
You have the species who goes after the tough species to sort of proclaim dominance. Well, this is as a human we're sort of erased their upstairs brain for a while, and they're just responding out of randomness. And
Right. Oh no, I've had ethnic slurs thrown at me from people from the same ethnic backgrounds. That's kind of ironic.
Yeah,
right?
this doesn't hurt my feelings if you're the same
Yeah,
as me.
it's hard. It's hard to not laugh. You know,
it's hard to
and you really have to just understand and use those coping skills for even our own selves to kind of deep breathe and just
For sure.
try to chalk it up as this is
This is
especially
not-
if it's psychosis. It's
person's
easy to
sick.
it's
This
easy
is a
to say
symptom.
this is a
Yeah.
symptom and this is part of an agitation process or this is part of a mood swing process and this is part of a thought disorder process that we can provide some reasonable interventions to help maintain appropriate standards.
Yeah. Make it better.
Yeah.
So let's talk about the difference between this drug-induced psychosis and maybe the other primary psychotic disorders. So let's talk about schizophrenia.
Sure.
Jeremiah, do you want to? So you said positive and negative symptoms. It's a complicated phenomenon. Do you want to describe it? Do you want to take that on?
Right. So the doctors will not
be
but
addressing
I'll,
that.
Yeah.
No. Well, see, and I didn't coming out of school out of just Gonzaga, my bachelor's and everything.
Yeah.
No idea.
Yeah.
I don't know if they probably taught it and it
Yeah.
just went,
It's just a hierarchy of education. You this is super important information. I'm going to focus on this, and then stuff gets left behind.
diabetes we talked about
Yeah.
every semester,
Yeah.
but
Right.
when it came to
Positive and negative symptoms of
the psycho-
schizophrenia.
yeah, no.
I don't think you get that at that level. You don't get a huge. You probably get 6 weeks.
Yeah,
Yeah.
if even
Of
that, I don't
content.
know.
We
Yeah.
give them 4 or 5 weeks. So
Yeah.
that's
I know
why.
in my ADN program,
Yeah.
it was 6 weeks of psych
Yeah.
nursing that I
Yeah.
had gotten from an instruction perspective, and that's not a whole lot.
It's not a whole lot. That's why we're doing these podcasts.
Yeah,
to
I
add to
don't
them.
really get the Cliff Notes version.
Yeah, for sure.
This is schizophrenia, and here's your highlights.
Here's the 5 things. Remember the
Next
3
is
things should
bipolar,
know
you know,
about
and so it's hard to even grasp
Yeah.
What that
the
is.
spectrums and where they belong and
Yeah.
how they. So most of them are kind of intertwined, which is a new phenomenon that we have this greater understanding of how they behave with one another, and so it can really get complicated when it comes to delineating between
Yeah.
these subtypes of this disorders.
So let's talk about let's not go to schizophrenia. Let's do psychosis first.
Okay.
What is psychosis? Because that's where we should start. What does psychosis mean?
Psychosis is the general disorganization of thought is what I'm
Okay,
trying
general
to
disorganization of
but
thought.
I'm gonna look it up.
Okay. What do you think, Jeremiah, off the top of your head? What's
Is
psychosis?
this psychosis?
Yeah.
So we're talking seeing, hearing, feeling
So
things.
hallucinations,
that are things,
right?
hallucination,
And they can be
that's right.
everything. Hallucinations can be tactile, visual.
Any of your senses, right?
Any of your senses can
All
you
five.
can experience something that doesn't exist, and that's your hallucination. And that's a huge piece of psychosis.
Yeah.
Right.
The other huge piece is sudden onset.
Sudden onset.
Yeah. Due to the way our brains function, things that are what's the word for not sudden? More
Chronic.
Gradual.
gradual. That's the word. It's more of a gradual onset.
Yeah.
Those are more organic symptoms. Brain tumors.
Yeah.
Those type of things.
Right.
Versus congenital dysfunction can cause the gradual onset of psychotic symptoms.
Yeah.
But a very sudden onset is particularly important because
To which disorder?
for brief psychotic disorder.
Okay.
For just the
Or-
initial
Yeah.
psychotic episode.
Psychotic episode. Yeah. You're not going to see. They're not going to start getting more and more psychotic.
It's not going to take 2 years to happen.
It'll just happen.
If it's psychosis, it's psychosis.
Yeah.
It's going to happen.
It's going to happen. And even when you see it as a complication of different disorders, a lot of times you can tell it just all of a sudden it becomes psychotic, and you're like, oh, this has gotten really bad.
Yeah.
So
it
you
can,
have
it can be confused with like the gradual
decline in function with like dementia disorders and cognitive disorders related to old age and injury to our brains. And those have to be, I think, delineated, because some people a lot of times explain like dementia like, oh, they're hearing voices or they're seeing things and being stimulated, so that must be psychosis, which really is more of a dementia issue.
It's a loss of reality.
Psychosis is a symptom related to the decline of dementia.
Gotcha.
And especially the end stages get really lousy.
And so if you're talking about psychosis specifically, you have hallucinations, and then you have delusions, which are the essentially thoughts or feelings that are not true.
Yeah, they're all really encompassed in that positive symptoms category. And even though it's not schizophrenia, it's still classified as positive and negative symptoms.
Right. Exactly. So then you have disorganization, which I think disorganization of thought is still considered psychosis, or psychosis is just hallucination and delusion.
Hallucination, delusion, disorganized speech, and grossly disorganized or catatonic behavior.
And so that's when you have, and so when you're thinking of positive symptoms, you're thinking of symptoms that are present.
That normally wouldn't be.
It's hard
and then on the other side of that, when you're talking about schizophrenia, you have negative symptoms, which are things that are absent that usually aren't.
And so the true meaning of the word positive and negative in these classifications are not accurate. You have to kind of remove those meanings.
Positive means good, negative means bad. You gotta
get those out of your mind, because it can be confusing.
Yeah, and I think it is.
And that really struggled, like through my initial years in psych nursing, I really struggled delineating which ones were which, and I kept thinking, well, no, those are good ones, and it's like, no, those are both not good.
They're not good.
Yeah.
Neither are good.
Neither one are fun. You know?
It's the addition or the subtraction.
Okay, I like the way of thinking about that.
Yeah,
right.
It's addition of subtraction. It's not good or bad.
Yeah.
It's addition of subtraction of symptoms.
The best way I could teach myself was inward and outward.
Okay.
Right.
That positive means that there's more symptoms outward,
Okay.
and so the number would be increasing in positive symptoms. So hallucinations, delusions, disorganized speech, and disorganized thoughts. Those are the positive ones. And then the negative ones are the ones that are more inward, and those are all the very, very troubling symptoms that are very poorly managed with antipsychotic medicines, which are the force to be reckoned with.
Yeah.
And they don't do much at all. Some of the older antipsychotic medicines actually made it worse, the negative symptoms.
Right.
They only managed to, like, especially the strong D2 medicines, the old atypicals,
the typical,
especially, were really can be detrimental for negative symptoms. And
Right.
that really seems to be what we don't want to do for the long run.
That's why we
That's
offer
why
the atypicals. Yeah.
That's why they tend to.
And so when you're talking about schizophrenia as a diagnosis itself, it's really this
Chronic.
The
It
chronic.
goes past that brief psychotic
past
disorder.
the brief psychotic
The
disorder.
time limit for brief psychotic disorder, I believe, is 30 days. But
Okay.
double check.
But
Yeah,
it's
for
schizoform now.
right, and then it can kind of go
to
into
6 months.
schizophreniform, and so there can
Yeah,
be
there you go,
a couple of preliminary diagnoses because
So
granted, you get a new patient. Say you get a new patient in an outpatient service, it just comes in and makes an appointment. You do a little intake, and they say, okay, well, this guy sounds like he's needing of some psychiatric treatment. You sit down and talk to him. Well, he's 16 years old. His mom is with him, and he's telling you he's hearing voices and he's seeing things at night. And he's feeling like the world's coming to an end, and everything he's telling you looks and sounds and smells like schizophrenia.
Yeah.
But he's 16 years old.
Yeah.
And you met him.
Yeah.
12 minutes ago.
Yeah.
And for me to sit and to fill out an entire psychiatric history and physical in 1-2 hours, and to walk this kid out and say, congratulations, you're now schizophrenic, go on your life, it seems problematic. It seems reckless.
It's almost crass,
Yeah, you have to give it time.
You gotta give it time.
You can't make up schizophrenia that quick. Say if I had an old chart, or several old charts from reputable sources, not just willy-nilly clinicians here and there, but actual treating providers that are managing from a medication standpoint especially. If you can find consistent reports from that, sure. That's not hard to coincide. The picture matches.
Yeah.
that you could say easily, oh, this person had a history of schizophrenia and was treated in this
Right.
place, and this place, and this. We're going to continue this treatment.
Especially schizophrenia, you're going to want to see a history of the positive,
Yeah.
just the positive symptoms, and you're going to want to see a history of the negative symptoms. You're going to see that. Need to see
That's
both of
that
those.
the chronicity factor
Yeah,
you have to be
chronicity.
seen with a new kid that's probably a first break
Yeah.
or and in his case he had some other developmental issues going on where there was probably some autism spectrum issues that
Right.
they were sort of trying to weed out, but on a kid that age you haven't seen him enough to
Yeah.
weed out the other causative factors. And so just like Jeremiah had mentioned, that's why you have schizophreniform
Yeah.
diagnosis, and that's exactly what he was given in that
Schizophreniform.
sense.
It's a
schizophreniform. It's a more of a temporary
Okay.
type of illness where it gives it a shorter time frame
Right.
of time, like onset.
and symptoms
Duration.
maybe not be as severe, or at least not
Correct.
as understood, because they may not have experienced
Same
all the
thing-
symptoms yet.
Oh,
Same thing with the
Yeah.
brief psychotic disorder. Is
Yeah.
the severity is much less. You
Yeah.
only have to have at least one positive symptoms
Right.
for a brief psychotic disorder, and I think with the schizophrenia diagnosis you have to have at least two
I think it's
or
two.
three from each
Yeah, I think you have at least.
category.
category.
Yeah.
Yeah.
So it's definitely more severe. So that's schizophrenia, which I think is pretty complicated. We go and so let's talk about moving from schizophrenia. I don't know about the subcategories of paranoid, disorganized, catatonic, residual. Do you guys want to go into details of those?
I don't think for this educational
This
setting,
Yeah.
I don't know if they're going to get a whole lot of content out of it.
Yeah.
I'd rather focus on the more broad,
Yeah.
general aspects of it, and they can
some of
choose
those-
to delve in, and some can be so
They're
subjective.
never clean cut like that. Is that what you're gonna say?
Right. Well, I mean, like in some of those, like the catatonic and residual, I mean, it's
It's
so,
hard to delineate.
Yeah, and there's
Catatonia
so
can
few
look
of them.
not like
Yeah,
catatonia. It's the strangest phenomenon where
That's
there's
weird.
people that are being called catatonic that are up talking at times, and then they're not catatonic in a minute, and they're like, well, it's catatonia.
Yeah.
And so it's a real hard.
It's a weird
It's
phenomenon.
hard to say that they're not.
But I do want to talk about schizoaffective.
Right.
Because I think schizoaffective is very interesting, and I did see that a lot at in a hospital.
There's a reason for it.
What's the reason?
It's probably the highest severity.
Okay.
It's the most debilitating in response to you sort of have a perfect storm,
Yeah.
if that's not too old of a movie to reference. And you're,
George Clooney's Perfect Storm?
Was he? Are you kidding me? Yeah.
I saw that on
That's what
the
made him
airplane.
George Clooney, right? I mean, that's what made him, I think that's what
Marky
made him
Mark.
kind of hot. Everybody was like, "Dude, that guy's got a sweet beard,
He's
sweet
got
accent."
He's
right?
got that orange fisherman hat
Yeah.
on that just does it for me.
And he was a sword fisher. That was pretty cool in my book. So, but the schizoaffective side of this is really the most severe aspects of schizophrenia combined with the most severe aspects of bipolar illness mixed into one, and it seems to be that combination effect really is leading to like really high rates of disability and,
Yeah.
and
Very
the
debilitating.
prognosis is, I bet, is pretty
And also, it's hard to treat because what are you treating?
that's the issue.
Yeah.
You end up having to treat a whole mess of things.
Yeah.
And we're
A lot
not
of
really
different meds.
we're not really good at treating one or the other.
Yeah.
As it is, right?
Yeah, as it is,
without
yeah. It's very hard to-
complicating things like schizophrenia is hard to manage on its own, and then you add a mood swing component to it.
Yeah.
And I don't know if you've ever dealt with schizophrenics with or without a mood swing component, but it's not easy
No.
without one, and with one it's becomes a nightmare.
Because
So that's how that
It's really hard.
state hospital really becomes a vector for schizoaffective illness and for chronic bipolar type illness. That's the non-compliant types that won't
Yeah.
manage meds at home, and then your drug-induced type patients, things like meth-induced or spice or all this other freaky stuff. That's
A lot of times-
kratom is now this kind of weird.
kratom.
Oh, we've had a few.
Right.
There was a couple of.
And they're saying, well, it's a tea or it's an herb, and that rationale, that logic is really ignorant because digitalis is a plant and that'll stop your heart. And what is the other one? What they kill Socrates with? Was it hemlock? Yeah. And so those things also naturally occur.
Yeah, so it's not
doesn't
an
mean
excuse. Yeah.
doesn't mean we're built to consume those. And mescaline, that's the other the peyote active ingredient.
Yeah.
It's this little cactus that grows just wild in the
Yeah.
Southwest.
Don't smoke random cacti in the Midwest if you're out
Don't
there.
lick toes. Don't do any of that weird stuff. It's not going to help you in the long run.
It's not going to work out for you. Yeah. So we know that. So with
Just end up naked in the middle of the
It's
Midwest.
crazy.
That's
Rolled
up in a
usually
creek
a good
somewhere.
idea.
I think a good like film version of somebody on mescaline is from the Royal Tenenbaums with Owen Wilson, where he's wearing the cowboy hat and he's driving his convertible and he's got like Native American war paint on, and he like crashes into a, what was it, a wedding or what was?
They were. What were they doing? It was something they were doing. Something. Was it a funeral? It wasn't
Yeah.
a funeral. Something was going on at the house, and
Yeah.
he ends up crashing into the house.
Yeah, which in a weird way unites the family, but that's not the point. Don't use mescaline.
But you really, if you want a not, a reality type picture, I saw a great little expose on the Vice channel. They had a little YouTube snippet of this one guy. I forget his name. It's Hamilton's Pharmacopedia. He sort of wanders through different less than desirable communities or areas experiencing drug cultures, and he's kind of seeking out this culture versus this culture. And one of his experiences was to seek out the mescaline crowd.
The mescaline community.
Yeah, in Mexico, over the border, so they don't have to have a whole lot of DEA influence of controlled substance. And mescaline is, I think, considered more of a religious agent in non-U.S. Territory.
Sure.
And so they showed him, and they show him experiencing this dissociative event.
Yeah.
And I don't think that's a healthy option.
No, I don't think so.
At this point, I watched it, and I've been changed by it just by watching that guy puke in a river, in a creek, and he doesn't really have an understanding of why it's happening, but he has this whole recall and experience of being involved in it from an outside perspective, and that seems to be like crossing phasers on the Ghostbusters trouble. That just doubles the risks. It's like doubling up how they say you shouldn't take two antipsychotics at once, because it really, instead of doubles your chance of developing the good benefits, it also doubles your chance of getting
probably quadruples. It's like a synergistic effect. Yeah.
So that is sort of how I can remember it.
So we know that severe mood swings can cause psychosis. So we know somebody with severe depression can become psychotic, and we know that somebody with severe mania can become psychosis that is self-limiting to the mood disorders.
Right.
So what's the difference between mania with psychotic features, or depression with psychotic features, and schizoaffective?
Good question. You might. It matters who you ask. You could find. Really, it's the presenting problems. What the initial primary presentation is from the patient's standpoint. With they say 80% of your job is really history collecting and building, and it really is. It's true that most of your work is going to be looking and digging and examining other people's opinions and perspectives. And so, on a depressed patient, they're going to have a history of a major depressive disorder.
Yeah.
They're not going to come out of the woodwork and just say, I feel sad at 52. Typically you're not going to see that.
Yeah.
It happens, but it's not typical. And so if in the outpatient setting or in the emergency setting or the hospital setting, you're not going to see a lot of chronic type illness. You're going to see some acute type early stuff, and that's not one that just falls out of the sky. They are already dealing with a depressive type illness, and then have experienced probably an increase of depressive symptoms, and then it leads to
the psychosis from that disease process.
The depressive episode can result into a psychotic.
And then when you resolve the depression episode, the psychosis is self-limiting, and so we know that it's not an additional disorder. It's just a complication of the depression or complication of the mania.
But what's the indication? What's the treatment for that disorder?
I think if psychosis is really self-limiting to the mood disorder,
like
you
just
should be
major
able to
depression
treat,
with psychotic feature.
Yeah, you should be able to treat the psychosis with an antidepressant.
You should.
And if you can't, then I would consider a schizoaffective
But
disorder.
if time is of the essence and you have an exacerbation of symptoms,
Sure.
A lot of times it's indicated with the atypicals.
Yep, I agree.
Especially like those, you see these commercials on TV constantly for Abilify, Latuda, and they're really trying to advertise to the general public that they don't have a lot of weight gain side effects. They don't have a lot of the negative side effects that are associated with
the bad side effects.
Right, especially if you start mentioning olanzapine, Risperdal, or Seroquel, those type of drugs that are related with some really substantial weight gain.
Yeah.
And so they're really trying to
Push
advertise and push this adjunct treatment therapy of small dose atypical antipsychotics, mainly like 2 milligrams of Abilify is being now used adjunctive. It's nowhere near the amount of saturation you're getting for treatment of a psychotic disorder, but they're now looking at the evidence that's showing that that receptor is also related with depressive symptoms.
Right.
And so why not?
And
why not provide that?
The Abilify doesn't, it causes less of a blocking of dopamine, rather does, I think it's technically a dopamine agonist, and so I think
high. Yeah, I thought it was like the highest, the D2.
And so I think the pharmaceutical reps really want to push that Abilify doesn't block dopamine. It's
Right.
sort of a magic drug that regulates dopamine.
Right.
Like, this sounds a lot like witchcraft, but I think in a realm it does, because it can improve dopamine levels in some areas of your brain, and then it decreases in some areas. And so that's why you kind of can get this antidepressant, antipsychotic effect at the same time. It's kind of a weird drug.
But back to your initial question is how do you delineate from the major depression with psychotic feature
And schizoaffective.
and the schizoaffective? It's clinical experience is what it's going to come down to. It's what's it look like?
What's it look like? Yeah.
And it's really going to be syndromes. It's going to be
Yeah.
other groups of symptoms and other areas that could be noticeable.
I agree. I think when I see psychiatrists make that diagnosis, or psychiatric practitioners, although I haven't worked with a lot of them, is it comes from seeing both mood symptoms and psychosis symptoms,
Right.
and not knowing which is what, and then not really meeting either criteria.
Right.
So they don't really have schizophrenia. They don't necessarily have one of the mood disorders that we can tell, and so they get a schizoaffective until we can kind of
Until otherwise noted, right?
Yeah, until otherwise noted. But I think technically, if you've really looked at all the evidence and all the history, schizoaffective should have independent psychotic symptoms. That even when the mood has regulated
From the manic. Right?
from the manic, when the mania has gone down,
Still-
depression's come up,
it's still there.
psychosis remains,
And that's why it's the most difficult to
and that's
manage.
why it's very difficult to manage.
Is that severity is going to be there even when you
Even-
have the mood swing component dealt with.
Yeah.
It's still going to be lurking.
The psychotic part.
Right. And the issue with that depressive psychotic state is those medicines are also indicated. They're all indicated for the same disease treatments.
Yeah.
And so it's hard to say, well, you just have a major depressive disorder with just psychosis.
Yeah.
Or do you have a psychotic disorder?
Right.
And so it really is time. I think it's durations and time. And the longer you get to know somebody, the longer you get to establish what all symptoms were present when they were untreated versus treated. Because you can't just rely on what they look like now.
Yeah.
Because then you'd be like, oh, you're fine.
Yeah.
You're doing great taking your Risperdal, but now you can't get treatment because I said you're good.
Yeah.
That doesn't make any sense. And so.
What do you think, Aaron?
And going off of what Aaron was saying about now I'm losing the word. The prognosis.
Yeah.
Okay.
So suicide rates for bipolar are immense.
Yeah.
And then on top of that, and then even for schizophrenia, suicide rates are high.
Yeah.
I think the general consensus is at least 10%.
Yeah,
Wow.
10%, and then I think
But that's the lowest.
Yeah.
yeah,
is
is
what it's-
bipolar. I think is like upwards of 25%.
Right.
Wow.
And if you're talking about attempts,
Yeah.
then it jumps
yeah.
like 50%, like
Yeah.
at least half.
And then you throw on top, so now you've got a mood disorder,
Right.
Mm-hmm.
and you've got the psychotic aspect, and so I mean, I don't know the numbers specifically on schizoaffective, but I can just imagine.
But just the severity, and then the ability for them to get better, or essentially suicide is your worst complication in psych, and so their risk for really your worst complication is that much higher, and so there's just a.
And then imagine what happens when you throw some drugs in there, some street drugs.
Yep.
Yeah.
And that's really what we have to really manage in our community, and Spokane itself is behind the curve on managing this, which is why there's constant news and pressure in social media about the mission and the nonsense that's going on downtown, and the police presence, and all the other depleting sounds that the social programs are making it with city budgeters and county budgeters, because it's always a lot of money that it costs to maintain people with illnesses that they aren't able to maintain independently, and so that becomes a huge problem. Community-based mental health.
Oh yeah, for sure, and that's really what makes a lot of this feel impossible. Not that it is impossible, but it's like okay, you're gonna come here, you're gonna be hospitalized for weeks to months, and you're going to get better, and we're going to give you a medication that you can tolerate that helps you with your symptoms, and then you're going to go back into community and use substances again, which is going to throw everything we did in the trash.
Right.
And you look at human behavior and it makes sense, and it's not, it's, you look at decision versus, it's they're really not making that decision. It's sort of made for them.
Right.
And so how, the approach we take seems to be so effective because they keep on coming back. But, I think people need that opportunity to fail that many times to be successful. I don't know, what do you think?
Well, and actually I was having just thoughts about, it's from what I remember talking with even a lot of the patients who are schizophrenic who were using meth.
Yeah.
Oftentimes the reason they went to meth initially is because it helped them.
Okay.
It helped reduce some of the symptoms they were feeling, but then the unfortunate aspect of it, they're getting more in their system, and then it actually becomes way worse.
Yeah, and it reduces
like
the
it's like
symptoms.
normally they'd be psychotic, up to this level, but then with the meth, it's like 4 times as worse than they would be just with their schizophrenia or their schizoaffective, and then it's way worse.
Yeah.
So initially helps, but then just wrecks them.
Yeah, just destroys them. But then but it's so addictive that they keep on going back.
Yeah.
That's right.
What's next?
I don't know. What do you guys want to talk about next? I have. I really wanted to focus on the difference between schizophrenia and schizoaffective, but we've gone for a long time. We talked a lot about it. I don't know. Do you guys want to do final thoughts? Anything else? Anything in pearls?
What's your time frame on it? You have a time frame?
I think we're good. I think we should probably start wrapping up. Yeah, we got 50 minutes. How do you work with? Let's talk about this last thing. How do we work as nurses and as RN level work with people with psychotic disorders?
Right.
What is the approach?
Oh, it's knowing where the patient is and approaching it, and usually it matters where they're at. If you have a sense that a patient is paranoid and not doing well, the approach is going to be different than a patient that's stable and involved in community services.
Sure.
And so you really have to know where you stand on your perspective and trying to understand how other people present, how they sound, how they look. And so really having that insight into knowing where people are and to know how to assess, and then how to motivate the interview through the difficult questions. How to get information without sounding like you're too prying. How does it sound like you're not digging for information on a paranoid patient?
Sure, yeah,
You're
for sure.
digging for patient.
Yeah, exactly.
On a paranoid patient.
And you at least got to try, at least got to go there with them, and no, I think that's good. That's good. What do you think, Jeremiah? What's your approach for somebody with psychosis?
Well, going back to a little bit of what we talked about in the personality disorder, treating them like a human being first off, and doing that conversational level, I think still is amazing and it works. The one difference is a lot of times if you're dealing with just illogical conversation, which can happen, is kind of going down a line of conversation, and if you're finding, okay, I'm getting blocked, taking the step back, adjusting a little bit, and then going down another line of conversation. As that gets blocked, then you kind of step back again and you adjust a little bit more, and then you go down the conversation a little track more, and then being not just bullheadedly going into a conversation, this is what's going to happen, and then just plow through it all. You
Being
kind of
gentle.
have to do the...
Well, what are they saying to you that you feel like you're getting blocked? Or what's an example of that symptom that's causing them to... You're getting to a certain extent in the conversation, and then you can't go any further.
It's usually when it just...
one word answers.
Yeah, when you get that, when you get...
How things going? Fine.
Yeah.
When you
And then
feel
you're
just
stuck.
that opposition.
Yeah.
It's that opposition.
Yeah.
When you feel that opposition,
Yeah.
whether it's logical or illogical, whatever that opposition
You gotta overcome
is,
it.
you got to back up from
Because
that.
they can start saying something that's really maybe off the wall or random, or they talk about something that's maybe incoherent, and they're like, okay, so that line of conversation got you to a point where you're no longer organized.
Right.
Can we back it up and talk about something and kind of reorient you and see if we can continue with maybe we went too far in a conversation. Maybe I talked about your past too much, or maybe we talked about something too much. Let's see if we keep it more surface level and be successful at.
And when, oftentimes again, so when somebody's frustrated and angry and coming at, a lot of times coming out of fear, right? Or coming out of some sort of emotional response, if you're, at some point there's going, not always, but if you keep doing that probing, you're going to find the thing that finally reduces that fear. That
That's
goes,
interesting.
that's,
Yeah.
so And because, like, again, you're going to get a lot of possible illogical conversation coming at
Right.
you, and but if you just kind of keep probing for where it is that it makes sense for them,
Yeah.
and it might not necessarily make sense for you,
It doesn't
Right.
need to.
Doesn't need to.
but what
At
makes
this
sense
point,
for them.
yeah, at that acuity, it doesn't need to make sense to the provider as much as it needs to make sense to the person receiving the care.
Yeah.
We're not in the business of giving ourselves care. We're trying to give it to someone else
All right.
with a very unbiased and logical approach. And
Yeah.
I think that's a really prominent part of it, is having that ability to do that approach.
And it's difficult. That's one
It
that
is.
you have to
It's
learn.
hard.
That's
It's a
learn
challenging
one.
one for sure.
Yeah, it takes a fair amount of self work. You know,
Yeah.
that reflection and everything else that you're trying to teach people to do.
Yeah.
It really does help you when you do that, because it really reduces the complications of these difficult times, because we all go through these struggles. We all go through
Yeah.
stressful moments, and some
Right.
of us are going to burn out and quit and become truck drivers. And,
Yeah.
not that truck driving's a bad gig. You know, I've always wanted to see Graceland, and that's
That's
my
the way to do
I
it.
can make
Yeah.
it over there. I cannot do it. I can't afford
Yeah.
to do it otherwise right now.
But going into the conversation, I mean, not having any social expectations,
Right.
and being
Yeah.
willing not to take anything personally, and
Yeah,
which
it's
is
a big
super,
deal.
which is just easier said than done, and I am not always successful at that. Sometimes I think it's very personally, but being
I
aware
think
of
we all
yourself,
have, but
yeah. And then
if you
just
can't
try.
admit that, I think
Yeah.
this is not the business for you, and
Yeah.
that's what I've tried to teach all of my students, is
Yeah.
that if personal insults and,
Yeah.
and derogatory language is not your gig,
Yeah.
then hospital psychiatric nursing or any outpatient psychiatric nursing, isn't going to be the best fit for your style, because it can be very obscene, it can be very derogatory,
Oh,
it can be very
incredibly.
triggering, and,
Upsetting,
and,
yeah.
and it's like, these patients are not all ignorant. Some of them are
Yeah.
extremely bright, and some of them
Yeah.
are extremely manipulative, and they can
Yeah.
be very taunting
Yeah.
and daunting, and all the other negatives that can
Yeah.
really result in that nurse burnout.
Yeah.
And it's not a fun process to have to go through that. So I
So
think if we
awareness
do that
is
self care,
essential. Yeah.
you really build that resilience factor in our brains, and that keeps us adapting. That
Yeah.
keeps us rolling with the punches,
Yeah.
and able to put one foot in front of the other day after day, and trying to look at the big picture and saying, well, I'm making a
Yeah.
positive
Exactly.
change in my community.
If you
or
stop
my
noticing the good
organization.
you're doing, then you're
Right.
burning out.
Yeah.
And that's the difference, is saying,
Yeah.
like, you know what, I had a hard day today,
Right.
I could call things I never thought I'd be called,
Mhm.
but I know that I made a difference in someone's life.
Right.
And that's really what's going to keep us from getting burned out.
So speaking on that,
Yeah.
one thing, going back even to the last conversation again,
Mhm.
talked about Daybreak.
Yeah.
And the social worker that just like impacted me, he made a statement that he'd had this kid who was in the sex trade from the
Yeah.
age of
Right.
5.
Yeah.
And he's got him as a 16-year-old. And he's like,
Yeah.
you know what? The fact is, I'm never going to do anything for this kid
Yeah.
where he's probably going to have a normal life.
Right.
Right.
The likelihood is so low.
Yeah.
But if that kid knows that
Yeah.
when he comes in here,
Yeah.
he has somebody who's looking after him,
Yeah.
that he knows that he can get off the street
Yeah.
and not have to sell himself for
Right.
drugs,
Yeah.
but he knows that in here he can be a normal kid
Yeah.
who's 16 and has somebody who's looking after him, then
Mhm.
I've done my job.
Then my
And
job
so-
was worthwhile.
Right. And that's,
That's how you find
how
that
that's
fulfillment.
right, and that's where the burnout, that's where you stop that burnout, is knowing, especially with a lot of these disorders and diseases,
Yeah.
They don't
it
go
may
away.
never be cured.
Yeah.
Yeah.
But does this person know that when they come here,
Yeah.
they're safe?
Yeah.
They've got somebody who's going, yeah, I'm looking after
I'm gonna
you.
take
I
care of
got
you."
your back.
Yeah.
And no matter what you do to me, I still
Yeah.
got your back.
Yeah. I'm still to serve you. I'm sorry. I'm
No
still
matter
here to take
how
care.
many times you swear at me,
Yeah.
I'm going to be there to make sure that you've got the care you need.
I'm gonna tell you to quit swearing at me, though.
I'm going to
I'm
do
not-
that, right,
I'm
right.
gonna let you know that that's not a boundary
I'm-
that you can keep crossing.
I'm never gonna stop swearing at you, Aaron. I'm gonna stop.
You're
One time
never
I-
gonna be my patient.
Yeah, I remember. One time a patient called me a prick really loudly, and I remember you came up to me, Jeremiah, and you said, "You're not a prick." I was like, well, in all fairness, I was probably telling him.
Right.
You
You
could
were
do
probably
something.
being a
Yeah,
prick.
I was probably being a prick at the moment, but I mean, I appreciate that. Validation. All right, cool guys, that was awesome.
Yeah, thanks.
All right, cool. I'm gonna pause it so. All right.